Hello, my name is Shannon Maxon, and I'm a returning student to get my BSN, and I'm taking the Legality and Ethical class at this time. I will be talking today about Trisomy 18 syndrome using the Moral model. Trisomy 18 is a syndrome that is rare chromosomal disorder. It's where you have three chromosomes in each cell. In other cases, you would have just normally have two, which can cause severe abnormalities for a baby. Mrs. Orr is a 37-year-old white female, gravida 3, para 2, abortion 0. Her initial blood work came back about 12 weeks abnormal. She had a 19-week ultrasound that showed abnormalities such as cardiac defects, small brain and kidneys, and small for gestational age. The OB doctor told Mrs. R that all the symptoms showed to be some kind of syndrome. The only way they would know 100% of a diagnosis is to do an amniocentesis. She elected to have the amniocentesis, and once that was done and sent back, they diagnosed the baby with Trisomy 18. Baby K was born about 32 weeks by emergency C-section. She came out without spontaneous respiratory effort, and her pulse ox was in the 30s, and heart rate was less than 100. At that time, we gave her positive pressure and was able to stimulate her and get her heart rate above 100 and her pulse ox in the 90s. Once that was done, the OB was came to the resuscitation room and checked on the baby to give the mom and dad an update. The neonatologist did the assessment and heard a loud heart murmur. She had a recessive jaw, low set of ears, eyes were wildly spaced, and overflexed fingers and webbed toes. The father was brought into the resuscitation room and was given a decision of what resuscitation route he would like to go. At that time, he saw that the baby wasn't doing that well with the spontaneous respiratory effort, so he chose to take the baby into mom's room for comfort care. And now we're going to use the Moral model, and we're going to massage the dilemma. Mr. and Mrs. M are the total caretakers for baby K, and they make all decisions for her. The OB doctor and the neonatologist and the genetic counselor met with Mr. and Mrs. M when the amniocentesis came back positive for Trisomy 18. Outlined the options. The team of doctors met with the parents and explained what Trisomy 18 was and what the expectable outcome for the baby could be not compatible with life. When they made three plans. The first one was do not resuscitate at the delivery and place the baby on comfort care in mom's room, or resuscitate with only chest compressions and positive pressure, and the doctors will see what the outcome will be after transferring into the NICU after doing further testing. Thirdly, they would resuscitate and do chest compressions with medication and prolong her life to give the parents time to bond and make their decision. The OB doctor and the neonatologist has the responsibility to educate the family about the consequences of each option, and they will explain each option of A, B, and C. Review the best and worst case scenario. The worst case scenario would be that the baby would come out without respiratory effort and expire at the delivery. And at this time, we would prepare the family for comfort care and help with coping skills. And the best scenario would be the baby would come out with spontaneous respiratory effort and require no resuscitation, and will go to the neonatal intensive care for managed care. Are there rules or principles to that guide decision? There are no rules or principles on a case like this. It is totally out of our hands with the outcome. If the baby comes out with respiratory effort, we will follow the guidelines of our protocol as we always do for every baby. What guidance do the concepts of beneficent autonomy and justice provide? Beneficent at this time, we as caregivers do not know what the outcome will be. The information given about trisomy 18 is not a positive one. Some can live for a while depending on how far down the chain the chromosomes are affected with 3 chromosomes. Autonomy. Mr. and Mrs. M are the total caretakers and are supported with their decisions they make for their baby. They have the right to make the choice for their baby and what care they want the baby to have. We as healthcare providers will respect their decision. Justice. Mr. and Mrs. M have private insurance, but since medical care is so expensive and the baby lives and gets to go home on comfort care, where the parents will then apply for state assistance to help with the baby's needs that they will have need at home. Affirmed Position Act. The decision making will totally be left to the parents. The neonatologist can give them the information and education about trisomy 18 and let the parents make the decisions on what the outcome might be after the delivery. Every baby's outcome is different, and the neonatology can only educate on what experience has been with other cases of trisomy 18 in the past. Baby K was born, and we're going to look back at the whole case scenario. Baby K was born and came out with spontaneous respiratory effort, stimulated and positive pressure given with about 40% oxygen. We once got her heart up to above 100, and her pulse ox came up into the low 90s. The dad was brought into the resuscitation room, and doctor updated him on her progress, and which was poorly. She wasn't very vigorous. She had low set ears, wide spread eyes, a large murmur. She at that time was taken to mom's room, and there she started being vigorous and crying, and ended up living and staying in mom's room for several hours. And that's the time that the neonatologist chose to bring the baby to the NICU to do further testing. They did an ultrasound of the heart, and it showed ventricular septal defect, transformation of the great arteries, patent ductus arteriosus, and a foramen ovale. The ultrasound of the brain showed that the brain was small, and the ultrasound of the kidneys showed that the kidneys were small bilaterally, and the chest x-ray showed that the lungs were hypoplastic lungs. After 24 hours of age, the baby started having where she was dropping her heart rate and her oxygen level. The parents would stimulate her to get her heart rate back up and her oxygen level, and each time they would do that, they were having to get vigorous and vigorous as time went by, and it was leaving bruising on the sternum. The baby continued to live after a week, and so the doctors got with palliative care and set up counseling with the parents, and at that time chose to do hospice care. About day off 9, the baby started dropping its heart rate, and the baby's heart rate went down into the low 30s, and the oxygen level was going into the 40s, and the baby was turning gray. And at that time, they decided to withdraw care. The ethical dilemma that was approached as caregivers, that the medical staff should have not let the parents have so much control over stimulating baby K to prolong her life to the point where bruising was on the chest, and many nurses thought it was cruel to the baby, and some thought it gave the parents time to bond with the baby. As healthcare providers, we have to put our personal beliefs to the side and let the parents make the choice for their own baby. Thank you.